previous lecture series, we are gonna talk about and learn about acetabular fractures. I am Weber and I work at Sir H. N. Reliance Foundation Hospital in Mumbai. Okay. So we all know that the treatment of acetabular fracture is a complex area in orthopedics. You must have been told and you must have also seen during your training that is something that requires a lot of planning and it does have a definite learning curve. Now, to all of you who are there, I would like most of the things or most of the fracture in orthopedics, the quality of reduction is the single most important factor that determines the outcome of these surgeries. Now, it's important to know about anatomy because I think the anatomy is where everything starts. So, if you look at the acetabular anatomy, it is located at the position where ilium, ischium, and pubis meet, and this fusion forms the innominate bone. We know that's an articular surface with an arch of around 300 degrees, and the cartilage there is around 2 to 3 millimeter thick. So that's the anatomy of the acetabulum. Now, it is also important to know about the latoronal and Judith's description of the acetabular anatomy, and they give this column concept that the socket is held in an inverted Y form and they form supporting columns. So there are two columns, anterior and posterior. Now, if you look at this picture, there are two structures here, and you'll see that the anterior side, which is colored in white, is the anterior column, and the posterior side is in the red color, and that's the posterior half or the posterior column. The blue and the amber colored are not traditionally considered part of the columns. That's the sciatic buttress on the top, and that's the inferior pubic rami. Okay, so this is a very important picture that all of you must remember, that what is anterior column and what is the posterior column. Now, if you look at the posterior column, what all comprises the posterior column? So there is a greater sciatic notch in this symbol here. Then the posterior rim, which is star marked. Then there is a lesser sciatic notch, and the pi is the ischial ramus. Okay, so all of this constitute. So the posterior column starts from the greater sciatic notch. Then you have a posterior rim. You have a lesser sciatic notch. And finally, you have the ischial ramus. So all of this constitutes the column, and all of this may get affected in cases of fracture. Apart from that, there is a medial wall which is formed by quadrilateral plate, and the iliopectineal eminence is the eminence in the anterior column. Both these structures are the limits of fixation in this area. So if you have to understand what we can do or what we can't do, I think these are the two critical structures that help us determine where we can go and where we can't go. And there are few important structures that we must know or we must be aware about: sciatic nerve, superior gluteal nerve and vessels, and corona mortis. So all of this are very important and have the potential to cause injury. So when you are doing a posterior approach, it's the sciatic nerve, superior gluteal nerve, and superior gluteal artery that may get injured. And corona mortis, this is a very important question. Sometimes you can get a short note or you maybe ask this during the exam. What is corona mortis? It's an occasional anastomosis between the inferior epigastric artery and the obturator artery that passes over the pubic ramus. And this is important when you are doing the topaz approach. And many times this artery may be very flimsy or very rudimentary, and sometimes it can be very large. And if the importance is that when you are doing a dissection, if you are not aware of this, you may incidentally cut that, and if you cut that, the patient may bleed to death. So mortis means death, corona means the crown. So it's like a crown sitting there, and if you injure that, then you are bound to cause deep harm to the patient. So those of you who are not familiar with that approach, and in fact if you are not being doing regularly, then it is advisable to have either a neurosurgeon or a general surgeon come over. As an orthopedic surgeon, we are very familiar with fixations and they are very familiar with the anatomy in that region. So you can call one of those people to dissect it out for you and you can proceed with the fracture fixation. The advantage of Stopa's approach, about which we will talk in slight more detail when we proceed, is that it is a very versatile approach, offering an opportunity to not only fix the anterior column but also possibly fix in a manner, the percute manner, or even through the same plate fix the posterior column using the same anterior approach. So this is a very important approach, and majority of surgeries and surgeons have shifted. People who do acetabular fractures routinely have shifted to the modified Stopa's approach. Now it's also important to know about the mechanism of the injury, and the injury pattern depends, like most fracture patterns, on what is the position of femoral head in the socket at the time of impaction. Excuse me. If the femoral head is rotated internally, so you'll see that if it is rotated internally, then it is of course going to impact So I'm trying to get a model so that I can show you in person here, and I'll switch on my video here. So I've got this model here. I hope everyone is able to see here. So this is the model, and if you see that if the head is internally rotated, so this is the external rotation, this is the internal rotation. If the head is internally rotated, it will impact here and cause the posterior column to get fractured here. So as I was telling you, this is the model of the pelvis. This is your anterior column, and this is your posterior column. This is the greater sciatic notch. This is the lesser sciatic notch. This is the anterior rib. So if your head is internally rotated impact, this is going to fracture. Similarly, if the head is rotated externally and it gets impacted, it's the anterior column that's gonna get fractured. Similarly, if the head is adducted, meaning it is like in this position, the superior aspect of dome is involved, and if it is abducted, the inferior part of the dome is fractured. Similarly, if you've got a rim fracture, the ball can jump like this and can be here. Okay, so that is how the different direction or different position of head determines what is happening in the fracture. Now the presentation could be a blow to the trochanter, knee, foot, and these are mostly the result of a high injury mechanism. You'll see the patient will have pain in the hip and groin region because that's where the fracture is. He'll not be able to weight bear on that, and the position of leg depending on the pattern of fracture may vary. It is important if the patient has any of these that you take an AP X-rays of the pelvis. Dislocation is considered as an orthopedic emergency, and maybe in some series, especially by Mata et al., who were pioneer in the acetabular surgery, they had it in 32% of patients. Most commonly, it is the posterior dislocation, as I showed you, going up, and sometimes it may be central dislocation when the quadrilateral plate is injured. So this is how a posterior dislocation looks. The X-ray is not very good quality, but you can see or appreciate that on the left side, the femur has dislocated. Majority of people, you must remember, around 56 to 77% have associated injuries. They may have a head injury, they may have extremity injury, urological injuries, neurological injuries, and pelvic injuries. So always rule out these things before you take the patient up for surgery. Now when we do a plain X-ray, it is basically a 2D representation of a three-dimensional image, and that is why it is important that you identify certain specific lines. They are not necessarily anatomical structure, but they are the projection on an X-ray of certain bony landmark, and if you study them well, they can tell you a lot of things about the acetabular anatomy. So three standard X-rays are required whenever you have an acetabular fracture. One is the antero-posterior view and two 45-degree oblique views, obturator oblique and the iliac oblique views. So these are also called a Jude's view. So whenever you get an X-ray, whenever you get an acetabular injury, take three X-rays: AP, obturator, and iliac view. These are 45-degree oblique views. Three X-rays are mandatory, and this is something that all of you must remember. Now, when you have an X-ray, you must draw 6 lines of Judet. They are magic lines. If you know this magic, you can virtually diagnose the pattern of injury without even needing to get CT scans. Nowadays, we have got CT for everything, so our life has become much easier. But if you knew these 6 lines, and all of you must draw these 6 lines. And what are these 6 lines? One is the iliopectineal line. The second is the ilioischial line. The third is the radiographic roof. Fourth is anterior rim. Fifth is posterior rim. And finally, it's the teardrop. So please, all of you, I'm giving you 2 seconds to write these things down. All 6 lines. Please write it down. So after this, you have to, so these are the lines. This is the iliopectineal line. This is the ilioischial line. This is the teardrop. This is the posterior rim. So this is how it looks. Okay, so you must always remember to draw this line. Now, how to take an obturator oblique view? When you turn your injured side towards the beam, you can see the anterior column, posterior wall, and obturator ring. So this is how it looks like. Okay, so you'll see that it shows the anterior column. You'll see that this is the anterior column, and that's your posterior rim. So that's how an obturator oblique view looks like. Okay, similarly, so this is an obturator oblique view, and you can see that the normal is that side, and a fractured anterior column and posterior wall can be seen with an intact obturator ring. Now, when you do an iliac oblique view, you see the posterior column, both greater and lesser sciatic notch, anterior rim or wall, and iliac wing. And again, you can, as I said, you can see posterior column. So this is how you are seeing the posterior column, and this is your anterior rim. So just take a moment to absorb this. This is the posterior column that you are seeing in iliac oblique view, and that's your anterior rim. All of you at the end of this lecture must be able to draw all the 6 lines that I mentioned. See how an obturator oblique view is taken and how an iliac oblique view is taken, and what all structures to identify. If you knew this, that's actually half the job done, or more than half the job done. This is how an iliac oblique view looks like, and you can see the posterior column fracture and also the disruption of the anterior rim on the X-rays. Now, Judets, Letournel and Judets gave very elementary pattern of the fracture thing. Most of the time we can have a combination, but these are the 5 things that you must know. The posterior wall can be injured, posterior column can be injured, anterior wall, anterior column, and finally the transverse. Okay, so these are the basic elementary pattern of the fracture. So you'll see the top is the posterior wall, the bottom one is the posterior column, the top again is the anterior wall, then the bottom to that is the anterior column, and then that's the transverse. So these are the 5 basic patterns that you must all know. Posterior column, posterior wall, anterior column, anterior wall, and transverse. Now there can be associated fractures. They can include 2 elementary forms, which is posterior column, posterior wall. So it's standard. So combination of those 5 that I said, posterior column with posterior wall, transverse with posterior wall, T-shaped, where you have got a straight line, anterior, posterior, hemi-transverse, or both column fractures. Okay, so these are the complex pattern. Now, again, illustrations of these, you can see that there are different fractures. posterior column plus posterior wall, T-shaped, both column transverse plus posterior wall, anterior column plus posterior hemi transverse. Now, it is important because accurate interpretation of radiograph will determine the surgical approach. So this is a very complex algorithm, not used so commonly nowadays, but if you want, you can take a picture of this and study this and do this. But I think CT scan has changed a lot of it, because if you have CT scan, you can really accurately identify the anatomic structures, fracture line, any rotational displacements, marginal impaction, incarcerated fragments, associated injuries, posterior pelvis, femur, all of that can be identified. And again, very simple way of identifying this. If you have got this transverse, if you have got this horizontal line, it could be a column fracture. If you have got a straight line, it could be a transverse fracture. And if you have got oblique line just taking off the chips, these are the anterior and posterior wall. Again, take a moment to absorb this. If you see this on a 2D or an axial cut and you can identify these, your half the job is done. So please have a look at this picture and remember and get it framed in your mind. Now try to identify what's happening there. So you will see that there is a posterior wall fracture and the fragment has got impacted. Now 3D reconstruction helps understand it much better because it gives you a sort of an software reconstruction of the image, and it also helps aid in reduction and internal fixation. We also must know about one another concept, which is the superior articular surface, which is the weight-bearing portion of acetabulum, and it is defined by the roof arc angle. It is attempt to define the important area of acetabulum through which the force is transmitted. And our treatment protocol. Now coming back to the treatment protocol, and before I go to the treatment, there's one another thing that you all must know, and which sometimes comes as a short note. It's called as 3D printing. Nowadays, you can actually virtually get a 3D printed models, and we have plenty of those. We do a lot of 3D printing. We have got it in-house now, and I think it has really changed the way we do it, because you can take a model, print it out, contour the plate. So virtually you can practice your surgery beforehand, and often you will get a short note on 3D printing. And again, on this, if you search the net, we have got a fantastic video on 3D printing basics. You can type out 3D printing Bulgaria and you'll find that there's a way in which these acetabular fractures have, and how the 3D printing has transformed the way the acetabular fractures are treated. Now, treatment protocol depends on the fracture line, the fracture configuration, and the amount of displacement. And roof arc angle is very important concept. It's the angle with which the fracture line makes with the vertical. If less than 45 degree, it involves the weight bearing area. Now, if on the CT, a top 10 millimeter is equal to 45 degree roof arc angle, and this is because that's where the subcontinental condensation can be seen. Now, we must know the surgical anatomy of individual fracture pattern. Posterior wall fractures fragment may vary in size, degree of communication. There may be potentially unrecognized fracture lines frequently accompanied by free osteochondral fragment, and we must remember that they receive blood from the capsule. Posterior column fractures are typically the rotated fragments, and you must derotate them to achieve a perfect reduction. Anterior column fractures occur anywhere along the anterior column. Although the pubic ramus is a part of the anterior column, we must remember that these are pelvic fractures and not acetabular fractures. Similarly, transverse fractures. So, the fracture that cross just above the fovea are juxtatectal, and that are higher are described as transtectal. So you must remember these terms. Infratectal, that cross in the region of fovea, are intratectal. That cross higher are described as transtectal, and above are called as juxtatectal. So these are very important concepts depending on where it is exiting above the fovea. T-type fractures are transverse fractures with a fracture line separating anterior from posterior column. You can also have anterior with posterior hemitransverse, and of course both column fracture is something that you must know about. Now, you have to remember in both column fractures, the whole of acetabulum is separated from axial skeleton and they can be called as a floating acetabulum. The actual joint can still appear very congruent, and this is called as a secondary congruence when they have this. So sometimes the both column fractures may be a blessing in disguise because your actual acetabulum is congruent. Surgical indications are loss of joint congruence, 2 to 3 millimeter of displacement involving the superior articular surface, more than 30 to 50% of posterior wall involvement, and retained intra-articular fracture fragment. So any joint asymmetry, any displacement more than 3 millimeter, more than 30 to 50% of posterior wall and a fracture fragment. These are the indications of surgery. Of course, subluxation itself is an indication for surgery. It is also an indication for traction because it can diminish cartilage wear, and these are the ones that may have intra-articular bone presence. Non-operative indications include those cases in which there is congruency in all three views out of traction, displacement is less than 2 millimeter, and roof arc angle is less than or 45 degree. If the fracture is displaced by more than 2 millimeter and the roof arc angle is more than 45 degree, then we have to think in terms of surgery. This is a typical example. Roof arc angle is less than 45 degree on the AP but greater than 45 degree on the iliac oblique. Since the displacement is less than 2 millimeter, the patient can be treated non-operatively. Non-operative treatment means typically bed rest or traction. It was described by Ledorna. Early mobilization is associated with the low risk of displacement in the patients who have met this criteria, and intraoperative stress test maybe determines instability. No one does it really now, so it's not really something that we need to know. Operative treatment, the goal, it runs on certain treatment principle. Goal is to have an anatomic reduction, stable congruent joint surface with restored contact area, stable fixation to allow early range of movement. We must know about surgical approach. A single approach is always preferred. There are few approaches. So it started with Cocker-Langenbach approach in which the trochanteric flip was done and it improved the access. Then there is an ilioinguinal approach, extensile approach, combined approaches, and finally Stoppa's approach. We must know about soft tissues. Open fractures are 1%. Soft tissue degloving lesions are around 2.6 to 16%. And most famously, moral level lesions. Decreased sensation and fluctuate area is something that you see. So this is a moral level lesion. It's the internal degloving of the skin and fat from the underlying fascia causing ecchymosis, decreased sensation and fluctuations over the area. So you may get a short note on moral level lesions. This is how it looks like, and it significantly impacts the wound management and infection rate. Up to 30% of the operative site in people who have a moral level lesion may be colonized at the time of surgery, and they are very, very high risk for the infection. This is how a Cocker-Langenbach approach looks like, typically for the posterior aspect of acetabulum. Those in green you can see actually visually, and the ones in the red, the areas you can have only a tactile feedback from that area. Cocker-Langenbach is done for posterior wall, column, transfers with posterior wall, posterior column, posterior wall, and T-shaped fractures. So these are the things that are being done. Ilioinguinal is mainly an anterior approach. It also gives you a very wide exposure. So it's done for anterior wall, anterior column, anterior posterior hemitransfers, both column fractures and transverse fractures, which are rare. Iliofemoral, it does not allow access distal to the iliopectineal, so it's often not used nowadays, not very often. Whenever we have to do an extended iliofemoral. And then the very infrequently done approach today is a triradiate when they have got fracture of both column, but it's a very, very extensile approach. Whenever possible, anterior approaches are preferred, and that is why Stoppa's approach that we'll talk about is something that we have to do. Posterior approaches have high risk of heterotopic ossification. We also must know what are the implant that you need to order. So there's a separate acetabular set of instrumentation. You all must see all the instrumentation for the acetabular fractures. So most commonly it is only a 3.5 mm recon plate that is required along with cortical screws of all size, and occasionally cancellous screws may be required. Stopa's approach, I'm a great fan of this approach. It's a transverse incision made approximately 2 cm above the symphysis pubis, and it creates a lateral window. When if you can extend this Stopa's approach by using a lateral window along the iliac crest. It provides a very good access to pubic body, pubic root, ilium, medial aspect of posterior column, sciatic buttress, and upper ilium and iliac crest. So it's one of the favorite approaches nowadays. So few examples here. Since this is a basic lecture, we will not go into detail, but this is some pictures. Results is highly dependent upon the experience and expertise. Usually, if you are good at it, you are good at it. The most important thing that I said at the start of lecture is that the results correlate with the adequacy of reduction and avoidance of complication. It deteriorates as the patient's age increases. Posterior wall fractures have lesser amount of success rate, although they are easier to do. But with modern CT scans and modern thought process, even those have improved to a very great extent. So in summary, radiographic evaluation allows diagnosis, determination of surgical indications. Fracture type determines the approach. Outcome is dependent on the commitment of surgeon. I use deliberately the word commitment. The joint preservation and satisfactory outcomes are possible in majority of patients treated appropriately. There are a lot of controversies from the approach to the fixation. There are many thought process. Not everyone has got the same thought process, but eventually consensus is whichever approach you are comfortable with, which offers you maximum exposure, is the one that you should use. People use intraoperative nerve monitoring, but it's really not, it's more of a research than actually used. And DVT prophylaxis, I think the debate is now settled. Most patients must undergo or must have a DVT prophylaxis if you are choosing to operate on them. We must work toward the prevention of heterotrophic ossification. It's a major complication. You can give a low dose irradiation or you can use an indomethacin. Again, you must read about this topic because they come as a short note. Those of you who are interested in reading more about or watching more about acetabular fracture, this whole radiology of acetabular fracture is given in a form of a video lecture on orthomatic times, and there are various other lectures also available, and they can log into it and subscribe to this channel and see this talk. I thank you for thank you